Hi, I'm Dr. Aaron Burnett. I'm a pre-hospital medicine fellow with Regents Hospital EMS, and today we're going to do a short demonstration about how to place a king airway. A king airway is a member of the class of airways called supraglottic airways. It includes devices such as the combi tube, the LMA, the ILMA, and some newer devices such as the LMA Supreme and the iGel. Supraglottic airways don't directly enter the trachea like a traditional endotracheal tube, but they're much quicker to place, much easier to place, and require less training to maintain your skills. They're an excellent adjunct during cardiopulmonary resuscitation because the time that chest compressions need to be interrupted during placement of a supraglottic airway is very short, where several studies have now shown that direct endotracheal intubation requires many seconds up to minutes of chest compression interruptions. Whenever placing a supraglottic airway device, you always want to check your equipment. In the case of the king airway, you will inflate the balloons with 60 to 80 cc's of air. This device is different than the combi tube in that there's only one port used to fill up the balloons. With the king, the distal port sits in the esophagus and the distal balloon fills the esophagus. The proximal balloon sits in the hypopharynx and makes a seal in that area. Air during ventilation comes out through a port in the middle between the two balloons, and with a seal below and a seal above, the only place for that air to go is into the trachea. The King's currently comes in many different devices. However, most pre-hospital services are only using them for adults. Today, we'll show how to place this airway device. So you can zoom in. With the King airway, you can place the head in a neutral position. You will place it with the balloons deflated. Sometimes it takes a small amount of lubrication. With the King, I find it helpful to take and lift the patient's mandible out of the way. The device is then placed straight back into the hypopharynx. Push it down as far as possible and inflate the balloon. At this point, the device will usually rise up a little bit from the pressure that the balloons place in the back of the throat. At this point, you want to begin ventilating and have someone listen to breath sounds. The key problem with this device, if you're not getting chest rise, is that it's probably too deep. So we recommend withdrawing the device while you ventilate until your partner begins to hear chest rise. At that point, you can attach an Untitled CO2 detector to look for vapor in the tube to confirm your tube placement at least 3 different ways. You can then secure the device with a typical tracheal tube holder. And the final and key feature to placing a king is a gastric port found on the back of the device, which allows placement of a nasogastric tube through the king airway directly down the back. This is very important because it allows you to decompress the stomach so that the risk of aspiration goes down significantly. In the hospital, if this were to get switched out for an endotracheal tube, it would be vital that the stomach is first decompressed by placing this gastric port. At this point, you can begin ventilating the patient and continue to transfer per your protocols.